Welcome everyone. In today's video, we are going to discuss the Judet Letournel Classification for acetabular fractures. So the Judet Letournel Classification divides acetabular fractures into elementary types and associated types. Elementary types are the types which separate all or part of a single column of acetabulum. So all of a single column or part of a single column is elementary types, and the associated types are combination of either two elementary types or one elementary type with an additional fracture component. So in the Judet Letournel classification, there are 5 elementary types and 5 associated types. The elementary types are posterior wall, posterior column, anterior wall, anterior column, and transverse type fracture. And the associated types are posterior column with posterior wall, anterior column or wall with a posterior hemitransverse fracture, transverse with posterior wall, T-shaped, and both column or associated both column fracture. Now, transverse fracture, instead of separating all or part of a single column, separates two columns. Yet it is included in a elementary type because of the fundamental nature of the fracture pattern, as it consists of a single consistent fracture line compared to the combination of fracture patterns seen in associated types. Now let us see the individual fracture types one by one. So we start with the elementary types. The first elementary type is posterior wall fracture. It is a common type with around 25% of the acetabular fractures being posterior wall fractures. These are commonly present with posterior dislocation of hip, and the best view to diagnose them is obturator oblique view. In AP view, there is disruption of the posterior rim shadow, and CT scan is useful to see fracture comminution, marginal impaction, intra-articular fragments, and impaction injuries of the femoral head. Now CT scan should be done in all cases of acetabular fractures to better visualize the fractures. The next type are the posterior column fractures. These are much less common, with around 3 to 5% of the acetabular fractures being posterior column fractures. They start from the greater sciatic notch, then travel along the posterior surface of the quadrilateral plate into the ischium through the obturator ring. Often they traverse through the obturator ring. These are inherently unstable fractures leading to displacement of the femoral head, which is posterior and medial, and thus these fractures require skeletal traction and reduction prior to surgery. In the AP view, we can see disruption of the ilioischial line due to the break in the posterior column. The posterior rim in these fractures is disrupted only in one location, whereas in a posterior wall fracture, the posterior rim is disrupted in two locations. So this is how we can differentiate a posterior column fracture from a posterior wall fracture on an AP view. That in the posterior column fracture, the rim is disrupted in only one location, and in wall fracture, it is disrupted in two locations. If the fracture involves the greater sciatic notch, there are chances of injury to the superior gluteal nerve or an entrapment of the superior gluteal neurovascular bundle. So during surgery, this entrapment must be carefully released before reduction to prevent further injury to this neurovascular structure. The next type are anterior wall fracture. These are rare in isolation, with only 1 to 2% of the acetabular fracture being isolated anterior wall fracture. This starts from the anterior inferior iliac spine, then crosses the articular surface of the pelvic brim, and then proceeds down the quadrilateral surface into the ischiopubic notch. In the AP view, there is an anterior rim shadow. So in posterior wall fractures, there was posterior rim shadow. In anterior wall fracture, there is an anterior rim shadow with disruption of iliopectineal line in two places. So an anterior wall fracture will also disrupt the iliopectineal line, but it will do in two places. Whereas in column fracture, it will do it in only one place. So the next type is anterior column fracture. Anterior column fracture consists about 3 to 5% of the acetabular fractures, and they separate the anterior border of the innominate bone from the ilium. And in AP view, as we saw, the iliopectineal line is disrupted only in one place. The femoral head is again displaced in column fractures. So in posterior column fracture, we saw it displaced posteriorly and medially. Here it is medially and superiorly. The types of anterior column fractures are very low, low, intermediate and high, and this depends on where the superior fracture line exits. So if it exits near the iliopectineal eminence, it is very low. Anterior inferior iliac spine, it is low. Anterior superior iliac spine, it is intermediate, and iliac crest, it is high. Now, irrespective of where the superior fracture line exits, it crosses the pelvic brim, then the quadrilateral surface, and then into the ischiopubic notch, and then crossing the obturator foramen, it ends in the ischiopubic ramus. The final elementary type are the transverse fracture, and they constitute around 5 to 19% of the acetabular fractures, and these fractures separate the pelvis into a cranial iliac piece and a caudal ischiopubic piece. The cranial segment is usually stable, whereas the caudal segment is usually unstable. So the caudal segment medializes, goes medially. So there is a medialization of the caudal segment and the femoral head following the fracture. And in the AP view, since both the column are disrupted, we will have disruption of both ilioischial and iliopectineal line. Now, the transverse fractures are further divided on the basis of where the fracture line crosses in relation to the cotyloid fossa. So, if it is through the cotyloid fossa, it is infratectal fracture. If it crosses at the top of the cotyloid fossa, it is juxtatectal fracture. And if it crosses the weight bearing dome of the acetabulum, it is transtectal fracture. Now the juxtatectal and the transtectal fractures can disrupt the concentric reduction of the femoral head to the roof of the acetabulum. So if these are not accurately reduced, they may lead to post-traumatic arthritis. Now let us see the associated types. The first associated type is posterior column and wall. They constitute around 3 to 4% of the fractures, and in this type the femoral head is frequently dislocated and follows the posterior ischiopubic fragment created by the column fractures, and the dislocation is cranial and posterior. Even after reduction, the posterior wall usually stays displaced, and the radiographic findings are disruption of the ilioischial line due to involvement of the posterior column, posterior border of the innominate bone may be disrupted, and there is a posterior rim shadow. So it is a combination of posterior column and posterior wall picture. The next type is transverse with posterior wall, and this is common with around 20% of the acetabular fractures being this pattern. The transverse component, as in an isolated transverse fracture, may be infratectal, juxtatectal and transtectal. And the transverse component is often undisplaced, whereas the posterior wall component is almost always displaced. And dislocation of the femoral head is common, which may be posterior or central. And this type of fracture requires urgent reduction prior to definitive fixation. Urgent reduction prior to definitive fixation decreases complications of femoral head, cartilaginous damage, vascular necrosis of the femoral head and sciatic nerve injury. Now it is very important that undisplaced transverse fractures may be missed on radiographs because the disruption of the ilioischial and iliopectineal line may not be very prominent in an undisplaced fractures. So CT scan is must to diagnose these cases. Now it is very important to remember that in all cases of suspected acetabular fractures, it is better to do a CT scan to better evaluate the fracture morphology. The next type is anterior column or wall with a posterior hemitransverse fracture. This is a common pattern in elderly, with around 7% of the acetabular fractures being this pattern. The primary fracture line is the anterior column or wall, with 3/4 of these fractures involving the anterior column, which is a more common combination. The associated transverse component starts from this column component across the posterior border of the innominate bone. Now, the displacement of this posterior hemitransverse component is often less compared to the anterior component. So, there is an anteromedial translation of the femoral head, but this is more severe than that seen in an isolated column fracture due to internal malrotation of the posterior component. So, there is an internal malrotation of the posterior component that leads to a more anteromedial translation of the femoral head in these fractures compared to a isolated anterior column fracture. Another sign that you may be asked is a Gull-Wing sign. So this is an impaction of the medial acetabular roof. So impaction of the medial acetabular roof on an AP X-ray is known as the Gull-Wing sign, which is a poor prognostic sign in acetabular fractures. The next type is T-shaped fractures. So these constitutes again around 7% of fractures, and a vertical fracture line arises from a transverse fracture line to form this pattern, which travels along the quadrilateral surface into the obturator foramen and into the ischiopubic ramus. Now this typically exits at the ischiopubic ramus, but this may also exit posteriorly through the ischium or anteriorly through the pubic body. So posteriorly through the ischium and anteriorly through the pelvic body are possible combinations. The transverse fracture again divides it into a cranial iliac fragment and a caudal ischiopubic fragment. This caudal ischiopubic component is divided by this vertical component into a posterior ischial fragment and the anterior pubic fragment. Now this vertical fracture may cause these two fragments to be undisplaced, minimally displaced, or widely displaced. So these may be undisplaced, minimally displaced, and widely displaced. Now widely displaced fractures may require a combined approach. So what happens when this is minimally displaced? During reduction and fixation of this fracture, this fragment acts as a single unit during reduction, and a single approach anterior or posterior may be sufficient to reduce this fracture. But once these are widely displaced, what happens? They don't act as a unit in reduction. So you may require a separate anterior approach to reduce these fragments and a separate posterior approach to reduce these fragments. So these widely displaced fractures often require a combined approach instead of a single approach. And these fractures also may have a posterior wall component in some of these cases. The final type is the both column, also known as associated both column, which is the most common associated pattern, with around 20% of the acetabular fractures being both column fractures. These are most common pattern in elderly patients. Now, any fracture which involves both the anterior and posterior column does not become a both column fracture. For a both column fracture, we have to see that the acetabulum has to be completely disconnected from the axial skeleton. So no portion of the acetabulum should be connected to the axial skeleton. No portion of the acetabulum remains connected to the innominate bone. And there is a split between the anterior and posterior column component. So we can see the acetabulum has completely separated from the innominate bone, and there is a split between the anterior and posterior column, and thus this fracture is a both column fracture? This is an important question. Now, in these fractures, the acetabular labrum is usually intact. So, despite medialization of this femoral head in these fractures, the articular fragments rotate around the femoral head and the femoral head remains congruent in both column fractures. This is known as secondary congruence. So, secondary congruence is seen in both column fractures. Another sign is Spur sign, which is a pathognomonic sign in both column fractures, which is the external cortex of the most caudal portion of the intact ilium. This is best seen, however, on an obturator oblique projection, though it may be sometimes seen on an AP view. These fractures may also be associated with a posterior wall fractures, and these posterior wall fractures in both column fractures are commonly stable following reduction compared to the typical posterior wall fractures, because these are more of an avulsion injury rather than a push off injury as seen in the posterior wall fractures. So these will be stable after reduction of the femoral head. So friends, in this video we discussed the Judet Letournel classification for acetabular fractures, which is a very important classification for postgraduate students. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also comment in the comment section regarding the topics you will like to be covered in the future videos. Thank you.